So Dr. Genovese, a child and adolescent psychiatrist here at KU. And thank you all for joining today. Hopefully we'll cover some very pertinent and informative topics of interest. And I noticed this morning, actually, I was able to sit in on Dr. Elizabeth Hastings' presentations on the management of co-occurring psychiatric disorders in children on the autism spectrum. A wonderful presentation. And I'm glad I got to learn a few things from Dr. Hastings, but also it'll let me know what to not focus on too much so that there's not a tremendous overlap in case anybody else or too many other people in the audience also sat in on Dr. Hastings' presentation. And it also reminded me listening to her presentation. So she is a developmental pediatrician and I am a child psychiatrist. And so we do overlap a lot in our roles potentially, but so sometimes parents will start with the child psychiatrist, sometimes often with the developmental pediatrician in terms of requesting an evaluation for co-occurring psychiatric disorders in their children, adolescents, or for psychiatric medications to manage target symptoms. So my presentation actually focuses a bit more on the target symptom management as opposed to the diagnosis of the disorder and for which the treatment naturally follows in the discussion of certain medications. So next slide. So we are discussing the use of certain medications in this presentation, which are not FDA approved for the uses discussed. Commonly, sorry about that. I'm going to turn off my phone so we won't get any more interruptions because my phone and iPad are connected. Okay. Sounds like we're still good. Let me know if we are not. So this is commonly referred to as the off-label use of medications. And these medications are typically prescribed for conditions commonly associated with autism. Next slide. I have no relevant conflicts of interest to report in relation to this presentation. Next slide. Okay, learning objectives. At the end of the session, you should be able to list various treatments for behavioral problems commonly faced by autistic children. Explain why medications prescribed for co-occurring conditions can be helpful. Describe the advantages as well as drawbacks of psychiatric medications, which are often prescribed for children on the autism spectrum. Next slide. Okay, so quickly, criteria for autism spectrum disorder per the Diagnostic and Statistical Manual, the DSM-5, and International Classification of Diseases known as the ICD-10. Criteria A, persistent differences in social communication and social interaction manifested by social emotional reciprocity, deficits in social emotional reciprocity, nonverbal communicative behaviors used for social interaction, and developing, maintaining, and understanding relationships with others. So all three of those criteria are necessary for diagnosis. Next slide. And then we have criteria B, and those are the restricted, repetitive patterns of behaviors, interests, or activities. My developmental pediatric colleagues call these the RRBs, manifested by at least two of the following. So you don't have to have all four for a diagnosis, and that would be stereotyped or repetitive motor movements, use of objects or speech, insistence on sameness, inflexible adherence to routines or ritualized patterns of behavior, highly restricted, fixated interests that are abnormal in intensity or focus, and hyper or hyporeactivity to sensory input. So that fourth item, the sensory issues, were added as a potential item for to support a diagnosis in the DSM-5 compared to previous versions. So that is a new addition since the DSM-5. Next slide. And again, not required for a diagnosis, but can be supportive of a diagnosis. So aside from medication, we want to emphasize the fact that there are several other things that are going to be involved in helping our kiddos with autism, as well as this is a lifespan conference, so as well as our adolescents, young adults, et cetera, throughout the lifespan. So behavioral interventions, including the intensive behavioral therapy, such as applied behavioral analysis. Speech language therapy to work on those communication skills can be the absolute key to managing frustration in an individual who has significant difficulties with communication. And many of our kiddos, that speech language therapy gets dropped at some point, and I'm often recommending that families seek continued speech language therapy support through some resource, if it's not through the school. Also, occupational therapy for those sensory issues which we had mentioned can be extremely helpful. Social skills training, especially for the adolescents and the adults. Good evidence support for help through social skills groups, for example. Social skills training for all ages, the groups more for the older kids and adults. And then the educational or vocational supports can be very important as well. Next slide. So, target symptom management. Currently, there are no medications approved for core symptoms of autism. And Dr. Hastings made the same point. So even the two medications that are FDA approved are approved for the treatment of irritability associated with autism. So the core symptoms of autism with effective treatment of comorbid conditions or irritability can improve, right? Because you're reducing the overall stress level that the individual is contending with. So you can see improvement in core symptoms, but there are no medications that have significant evidence or FDA approval yet for the core symptoms of autism. The medications are generally prescribed for the target symptoms, for specific target symptoms, or for co-occurring disorders. And the potential benefits and risks are determined for each medication on a case-by-case basis. Next slide. So psychotropic medications are commonly prescribed to individuals with autism. And so here's a registry from Autism Speaks, Autism Treatment Network. And so you can see that younger children are less likely to be prescribed medications, but still 10% of kids in that particular network. So this, it may be a skewed segment of the population of kids with autism, right? Because if they're in the network, maybe they are more symptomatic, more severe, have more severe behavioral issues. But 10% of preschool age kids, 44% of school age kids, and then adolescents. So as the kids get older, they're more likely to be on a psychotropic medication. Next slide. The NIMH, National Institute of Mental Health, says that more than half of school-aged children who are identified with special healthcare needs and autism used at least one psychiatric medication or psychotropic medication. And so those are kiddos who have enough difficulty that now they have 504 plans or IEPs in school identifying them as special healthcare needs. And in that group, now we will see specifically, so you're looking at the types of medications. And Dr. Hastings mentioned that ADHD is one of the most common co-occurring conditions associated with autism. So 32% of those kids now school age are on stimulant medications or ADHD medications. 25%, so 1 out of 4 on anti-anxiety or mood stabilizing medications, and 20% on antidepressants. So these medications are being prescribed often, and so it's an excellent topic to discuss and learn more about. Next slide. So 70% of children with autism meet criteria for a co-occurring psychiatric disorder based on parent interview. And of those disorders, the anxiety disorders in children are the most common. Specific phobia and other types of anxiety disorders in the 40% range. ADHD, 31%. So these statistics differ a little bit from what Dr. Hastings had mentioned, but you have to look at the source of information. So this is co-occurring disorders based on parent interview. So it just depends on where your data, which subset of the population you might be getting information on, and at which point in time. So if you're getting your information on patients who are in school, and also people who respond to these kind of surveys sometimes are more likely to respond if they have co-occurring disorders possibly. But ADHD is common, depression is 10%, so significant, but the majority of children will not have, with autism, will not have depression. And next slide. Now we move to adults. So since this is a lifespan conference, we want to look at, okay, so how do the diagnoses evolve over time from childhood into young adulthood and into adulthood? And this is consistent with my clinical experiences. I work more and more with young adults with autism. Depression now becomes much more common, a significant problem now in adults with autism, a frequent occurrence, 40%. Anxiety drops a bit compared to the kids. So hopefully a lot of those kiddos have learned how to cope with their anxiety, no longer meet criteria for an anxiety disorder. Anxiety in some people can be persistent across the lifespan, and for some it can resolve or lessen in severity, so they no longer meet criteria for a disorder or a diagnosis. Now look at the psychosis. This is something that Dr. Hastings had not mentioned, but the risk for developing a psychotic, a mental health issue associated with a psychotic symptom or psychosis, which would include 2 lines down, schizophrenia. Psychosis does not necessarily equal schizophrenia. You can have major depressive disorder with psychotic features. You can have psychotic features associated with significant trauma, post-traumatic stress disorder, bipolar disorder, or as an isolated phenomenon in rare instances. But yeah, 10%, and bipolar 9%, schizophrenia, so compared to the baseline rates in the general population, significant elevations. Schizophrenia, 2%. In the general population, the baseline risk is 1%, so double the risk. And I have seen some individuals who clearly have autism become adolescents, young adults, and develop a clear picture consistent with schizophrenia. And generally, there's a family history of major mental illnesses in those families, but not always. And then the obsessive compulsive disorder, 1%, which is actually, that's consistent with the general population. So next slide. Looking at psychiatric medications now in autistic adults. Previously, we just mentioned how common medications are prescribed to youth with autism. And here we're looking, now we're gathering the data from a Medicaid database for adults, finding that twice the number of adults who have the autism diagnosis, and that would be 85% of those individuals who are on Medicaid and have an autism diagnosis in that 3-state database are getting psychiatric medications compared to individuals from the same group without autism, an autism diagnosis on the record. And the most common medications now for the adults, antipsychotics, become the most frequently prescribed, followed by anticonvulsants, which can be given either for the treatment of seizure disorder or mood disorders with irritability, and finally anti-anxiety or sedative type medications, and those can be prescribed also for insomnia as well. Next slide. So we have a picture of the common situation of having psychiatric medications prescribed in our population. Pharmacogenetics, I frequently get questions about pharmacogenetic testing, or we also call it pharmacogenomic testing, goes by both names. Just a quick mention, it can be helpful in some cases. At this point, the majority of individuals will not have pharmacogenetic testing, although it is becoming more and more commonplace, particularly if we have an individual for whom the usual treatments are not tolerated as expected. In other words, they're having unexpected, unusual side effects or not working. Multiple failed treatment trials may be another situation where you would order and obtain pharmacogenetic testing, which would involve consultation with a geneticist generally, as well as the genetic testing itself, which is a blood draw. And so they're looking at DNA variation in the cytochrome P450 system, which is an enzyme system in the liver that regulates the metabolism of medications, drug metabolism. And if there's a polymorphism in the gene that regulates that metabolism, then that's where you can see the variability in the response to the drug, either the drug not working as expected or having unexpected side effects. So, and Dr. Butler and I recently published an article discussing that topic, as well as other genetic risk factors for autism. So a very comprehensive article. Next slide. Okay, so those target symptoms I was mentioning, starting with the ADHD type symptoms, hyperactivity, inattention, and followed by irritability, aggression, repetitive behaviors, mood lability, meaning mood swings or intense mood shifts, depression, anxiety, and sleep problems. Next slide. So for the ADHD type symptoms, we have multiple medications now FDA approved for the treatment of ADHD. And just like Dr. Hastings mentioned, these treatments can be very effective for an autistic individual. And I am focusing, most of the literature and the evidence is for children in this area, especially with the treatment of ADHD. However, these treatments can be just as effective in adults. Now you have a little bit more of a risk on some of the side effects with adults. But I'll tell you from clinical experience that many of the treatments that we will cover, that, you know, where the evidence is based in childhood populations, the FDA approvals were based on childhood samples, but they are often still taken by our adults and can still be very effective. So we have three classes of medications for ADHD: stimulants, which are considered first line because they're most effective, most often effective, and generally most often best tolerated. So they're considered first line for the treatment of attention deficit hyperactivity disorder, ADHD. Alpha-2 adrenergic agonists, which will cover guanfacine, clonidine, are the two alpha-2 agonists, and then atomoxetine. Next slide. So generally, just summary on stimulants in autism. More data for methylphenidate than for the amphetamine class stimulants. The stimulants or any treatment for ADHD can help with self-regulation, including emotional self-regulation. So the whole self-control issue, including the self-awareness issue, which is, I think, very fundamental and key to a person's functional capacity in social situations. Being self-aware is so critical for so many things in terms of our overall level of functioning, our ability to report on our own emotional state, being aware of how we're, being able to self-monitor how others might be perceiving us in the midst of a conversation or a social situation, very critical. So treatment of ADHD, when a person has ADHD, can help with these other fundamental attributes, capabilities. So when the symptoms of ADHD improve, then the individual is more able to engage, more able to learn, more able to incorporate the skills that are taught. So also critically important in terms of benefiting from any kind of behavioral therapy or psychotherapy intervention as well. Next slide. So adverse events, most often leading to, if methylphenidate is not tolerated and ends up being discontinued. At low doses, we see, even at low doses, we often see with stimulants such as methylphenidate, we'll see appetite loss, irritability, insomnia, diarrhea. And at high doses, we can see especially increased stereotypic behaviors for individuals who have the stereotypic repetitive behaviors, increase in motor tics, tantrums, aggression, or self-injurious behavior. So lots of potential side effects that we need to be aware of. Next slide. Conclusions, just, and I'm quickly touching on, and again, Dr. Hastings, and she promised to share her slide set. So she has a lot of really wonderful, clinically oriented, detailed information on the use of stimulants for the treatment of ADHD in autistic individuals. So please, for more information, go to her slide set for those kinds of details. But I'm just kind of summarizing because I'm going to cover more on other classes of medications. But at low doses, and that's so for methylphenidate up to 25 milligrams a day. So that would be your immediate release methylphenidate. If you took morning, lunch, and after school, that would be something like 10 milligrams with breakfast, and again at lunch, and maybe a 5 milligram dose after school for your total 25 milligrams a day dosage, or on the time release preparations that can be given once a day in the morning. You see significant benefit in half or just over half of children, which is a lower response rate than for typically developing peers. It is, in most cases, still, despite all those potential side effects, for most people, generally well tolerated. And when you do see side effects initially, you adjust that dose gradually and give the person a chance to adapt to side effects. Generally, you can work your way around side effects or use low dose and augment. And again, a lot of patients start with the developmental pediatrician. Sometimes they get referred to the psychiatrist because they're not responding to the usual treatments or having complex difficulties. And so in those cases, and often we do get the more complex, difficult to treat individuals, then we're often augmenting our treatment. So sometimes using 2 treatments for ADHD, that can be a very, very common practice. So it helps to keep side effects down if you can use a low dose of 2 medications, for example, rather than a higher dose of 1 medication. Higher doses, according to the data, results in little additional benefit in most cases. So, it's a common mistake that can be made. It's like, well, if this much is helping, but only modestly, right? We're seeing a 20% improvement in symptoms. Well, people would hope for more, generally speaking, but if you drive the dose up and too quickly or too soon, you're more likely to see those side effects, and you're not likely to see a lot of additional benefit in most cases. You can sometimes. And then we mentioned that lower response rates. So next slide. Here are those alpha adrenergic agonists. We call them the guanfacine and the clonidine. And the data is not quite as strong, but I'll tell you what, clinically, these medications can be very, very helpful, both for ADHD and for the irritability in autism because of the calming effect that they can have, and the safety and overall good tolerability with these medications. And now that they both come in a time release preparation, side effects are much less even still. And the individual has to be able to swallow the pill to take the time release version. But the average dose on the guanfacine is about 3 milligrams, ranging from 1 to 4 milligrams for kids. And that was based on a randomized clinical trial with 62 kids. So good study on that one. Not as much data for the clonidine, but these 2 medications work in the same way. Clonidine can be a little more sedating, but this slide kind of summarizes some of the specific target symptoms that these behaviors can help with: oppositional behaviors, repetitive behaviors, irritability, stereotypies, hyperactivity, inappropriate speech. So can help with a lot of concerns that we see in our kiddos who get referred to us for treatment of ADHD. Next slide. Again, lots of potential adverse effects. Most individuals do not have a lot of side effects, but things to watch for and be aware of with these medications. So I won't go over each and every bullet point, but there are, and for the general, for parents, don't let it scare you away. Potential side effects, again, if I like to say that if these side effects were that common, you know, we would not be allowed to prescribe these medications. So they are uncommon, and generally, like I say, with careful dosing, we can usually avoid most of these side effects. Next slide. And by the way, the alpha-2 agonist that we just covered, and now this, the atomoxetine, and I am using the generic names for these medications. But just to mention, these are not controlled substances. So stimulant medications are considered Schedule II controlled substances. The alpha-2 agonists and the atomoxetine that we're covering now are not controlled substances. And so in some regards, less to worry about in that regard. However, that being said, stimulants being the first line treatment, the most effective and overall the best tolerated for the treatment of ADHD, people worry it's a potentially habit forming medication. People do get addicted. Adults generally can get addicted to these medications if they're using them in a way that's not intended, not prescribed. Generally, they're obtaining the medication through illegitimate sources, not through prescription by a provider with doctor's appointments and monitoring and supervision and proper diagnosis. Kids take low doses in a time release. They do not experience a high from the stimulants. They do not want to take the medications in the vast majority of cases, unless, of course, they notice quite clearly how much it helps. Then, of course, they do accept the treatment readily. The effective treatment of ADHD, no matter what the treatment, stimulant or non-stimulant, is associated with lower risk for drug abuse and dependence, including nicotine dependence, which is a significant risk in children with ADHD who are becoming adolescents, young adults. So the treatment of ADHD actually reduces the risk later in life of alcohol and drug and substance abuse. So that I just wanted to throw that in as well. Okay, so moving on to this current slide, atomoxetine. With atomoxetine, you see moderate improvement in ADHD symptoms. The nice thing about atomoxetine is you don't see an increase in your anxiety. So the treatment response, you know, these extension studies are important to pay attention to because it demonstrates that most people who do have a treatment response will maintain that treatment response. And I will mention that sometimes, so I don't know how this particular clinical trial was set up, but sometimes you do have to adjust that dose over time. And maybe that's why some of these subjects did not maintain their treatment response. And next slide. A lot of potential side effects on atomoxetine as well, potential side effects. There are black box warning labels on some medications, and for this one, the potential for liver toxicity. And it was a rare and idiosyncratic reaction that was reported early on, which we have not heard additional reports, or warnings in regards to, so very low risk. Very safe and effective medication. When it works as well as the stimulants in my experience, but it doesn't work as often as the stimulants. Next slide. Disruptive behaviors, including irritability or other behavioral problems. So this, now we're covering medications that can help with tantrums, self-injurious behavior, and physical aggression, as well as other behaviors that may occur in response to underlying stress, anxiety for other reasons, but still, if the behaviors rise to that level of a safety concern, then we want to review the evidence for treatments that can be helpful for for those situations. Next slide. Always consider the potential for medical causes. I just saw a young man who was having a significant uptick in self-injurious behaviors. Turns out he was having severe gastrointestinal issues with reflux. If reflux is left, he was nonverbal, so he was unable to report his symptoms. But the primary care provider finally figured it out, and effective treatment, and his behavior is much better, and he's back to his happy, affectionate self, and no longer self-injuring. So if you have an unexpected increase in any of these kinds of symptoms, irritability, self-injurious behavior, aggression, think about potential medical differential diagnosis and work with your pediatrician to try to figure those things out in case they may be contributing. Next slide. Irritability. So the medications used to treat irritability include antipsychotics, anticonvulsants, serotonin reuptake inhibitors, and there's a supplement called N-acetylcysteine, NAC, which can be helpful in some cases as well. Next slide. So various antipsychotics used to treat irritability. The best evidence is with risperidone and then aripiprazole, followed by several others, which we will cover a few of those in some of these slides. Next slide. So risperidone is FDA approved for the treatment of irritability associated with autism in children at least 5 years of age and older. This was FDA approved in 2006 based on 101 kids, randomized multi-site clinical trials. So like the gold standard clinical trial, of course, to get the FDA approval. And with 2 other controlled trials supporting their findings as well. Next slide. 90% of patients responded to risperidone had significant clinical improvement. And so they look at the aberrant behavior checklist. That's one of the measures that they use in order to assess treatment response. So they're looking at the irritability subscale. So very carefully assessed individuals in these clinical trials using validated instruments. And so the improvement was defined by at least a 25% improvement on that rating scale. And the doses ranged between 0.5 milligram and 2.5 milligrams per day of risperidone. Next slide. There are short and long-term benefits with risperidone, reduction in the irritability, as we mentioned. The mean, or the most common dose is somewhere between 1 and 2 milligrams in that range. 2/3 of responders after 6 months have continued improvement. So just like we mentioned with the atomoxetine, there are some people who in these clinical trials over time are no longer showing that significant improvement that they can show early on. And this is the problem with some treatments, is they seem to help better in the short term sometimes than in the long term. So, but there was a meta-analysis looking at 20 separate clinical trials showing significant overall improvement. So additional data to support the benefit. Next slide. Antipsychotics, we're talking about all those potential side effects of medication. So we have more with antipsychotics. So that's why we try to find other interventions, including behavioral interventions, et cetera, that can be helpful before we would move on to such strong medications. So I just wanted to mention that with both risperidone and aripiprazole, with any antipsychotic, a lot more potential side effects, and these now require routine blood monitoring and evaluation for these potential side effects. So you are getting into, I like to call them stronger medicines with more potentially serious side effects over time. So if you do use them, you try to use them for short term if at all possible, and try to taper, either find something else or hope that things have improved due to other interventions, which will allow for the tapering and hopefully discontinuation of these medications at some point. Next slide. So there's the bullet point list of a lot of potential side effects that need to be aware of if you are prescribing these medications. So if they occur, you know that it could be related. Next slide. Now we have aripiprazole, and I'm not going to go into the, I've been told we're down to the last 7 minutes or so of our presentation. So we do want to leave time for questions. So we won't go over the specifics, very similar to the risperidone data. Next slide. And more patients, by the way. And now the kids are 6 to 17 years old. Next slide. And we're looking at mean improvement on the aberrant behavior checklist, the ABC they call it. And there's different subscales, but again, an example of an instrument that's used to assess for the benefit of these medications in the clinical trials. Next slide. And the dosing is starting at 2 milligrams a day. The average most effective dose for aripiprazole is 10 milligrams a day. And they're recommending a maximum dose of 15 milligrams a day. Adults sometimes take 20 milligrams a day or so. Next slide. Paliperidone, similar to risperidone, can also be beneficial. So that's the short answer to this slide. So we have time for questions, but the mean dose is about 7 milligrams. That particular medication is dosed in a 1.5, a 3, a 6 milligram, and a 9 milligram tablet. So, and I've had kids on throughout the dose ranges and have done well on this medication. What was remarkable is that this medication was shown to be helpful even in risperidone non-responders. As effective as risperidone is, this medication can work even when that one does not in many cases. So next slide. We'll skip the clinical global impression of improvement scale, but this is a clinician instrument that can help gauge treatment response. And I just wanted to mention that. Next slide. A divalproex, so can also, so now this is an anticonvulsant and anti-seizure medicine. It can also be helpful and good clinical data to support its benefit in children with autism. Next slide. Topiramate, also an anticonvulsant, anti-seizure medicine, can reduce appetite. So sometimes certain medications increase appetite. This one can reduce the appetite. You know, it can be an additional benefit of the medication in some individuals, but it's a good mood stabilizer and it can help with that irritability, and probably more helpful in individuals with EEG abnormalities, but we're not screening for EEG abnormalities occur even in individuals who are not manifesting seizures. Significant EEG abnormalities in individuals with seizures, obviously, but the thought is that those individuals may be even more responsive to these anticonvulsant medications. But until we get to where we might be screening or using the EEG more often, more routinely, we wouldn't know that those are the individuals more likely potentially to respond to these medications. Next slide. N-acetylcysteine, the supplement I'd mentioned, can be very helpful. Still some potential side effects, even though it's a supplement. And I reference an article, a review article that talks about dosing in clinical trials and summarizes that data for the uses of NAC and various psychiatric conditions. Next slide. And again, there was a really well done study, 12 weeks, that showed benefit of the N-acetylcysteine. And in this particular clinical trial, they said the side effects were very low and essentially equivalent to placebo. I've got some parents using it with some success in some cases, but most, it seems, will come back and tell me that it doesn't really seem to be providing a lot of benefit, but when it works, it's something to consider, especially for repetitive behaviors. Next slide. And so we are reminded that the repetitive behaviors are not the same as obsessive compulsive disorder. There's a lot of overlap. Next slide. And the serotonin reuptake inhibitors, such as those on this list, can be helpful sometimes for those repetitive behaviors. And the evidence is better for the adults actually compared to the children. Next slide. So certain target symptoms for those serotonin reuptake inhibitors, and Dr. Hastings covered this very well, actually. So she'll have more data in her slide set that most commonly these will be prescribed for either depression or anxiety in the children who happen to have ASD. And we need to finish up. So I'm going to end here and take questions. Sorry, we had a late start due to some technical difficulties.
Thank you so much, Dr. Genovese, for presenting all that really informative information about medications and autism, and powering through despite a late start. You covered a lot of ground. Thank you. If anyone has any questions, please go ahead and put it in the chat. Or we can also do unmuting and asking questions. But if you do that, we just ask that you try to keep that pretty succinct because we have limited amount of time for questions. I actually have one question. I was wondering, Dr. Genovese, and I was hearing you talk about pharmacogenetic testing. I was wondering if there's been any research done on kind of like the looking at the clinical implications from that. So like when we do that medication, when we do that testing and we change medications, are we consistently like on a large scale seeing improvements in, you know, symptoms or functional impairment? Does that make sense?
Yes, and so in the cases where the pharmacogenomic testing ends up providing some benefit in terms of helping us to select the medication that's most likely to be beneficial based on the way it's metabolized in the liver, most likely to be beneficial, most likely to work, and least likely to be causing problematic side effects, right? And so, yes, you can then expedite the process of finding the right treatment for that child. So it helps you to bypass some of that trial and error that so frequently, you know, before pharmacogenetic testing was available, that's all we had, right? And that very frustrating, right? And but the pharmacogenetic testing in general is most helpful when you're talking about those antidepressant medications, those serotonin reuptake inhibitors, right? For the treatment of depression, anxiety when it co-occurs with any other condition or when it occurs by itself. That is the
helpful. And there's a question too in the box about metformin too, and if that's being routinely used in kids who gain a lot of weight on risperidol or Abilify.
Correct. So yes, and metformin, so that's a medicine to regulate blood sugar in diabetics, but it can be prescribed to reduce the appetite and to help prevent the progression into diabetes for medications that increase the risk for developing diabetes, like the antipsychotics. And yes, it is prescribed. Generally speaking, it will be the pediatrician who's prescribing the metformin to help with weight management. And not the psychiatrist, but we will collaborate. And if they really still absolutely need that antipsychotic that's causing those potential side effects, and we can't taper, we can't stop the medication, we need to manage the side effects, then that's when the metformin can be very helpful, yes. Okay.
I think we're just about at session time. Are there any other last questions? Dr. Ellerbeck has more questions in the chat box.
Hello, Dr. Ellerbeck.
Hello. Yes. So I have a young man who's on Abilify and still irritable. Every time I try to taper him, he gets more irritable and we go back up, and weight gain's an issue. And I hadn't ever thought about Topamax.
Yes.
Yeah. Yes. And does that work with Abilify as well as Risperidol? I would guess it
yes.
would. But, okay.
And so for the audience, we're talking about aripiprazole, generic for Abilify. And we're talking about topiramate, which is the generic for Topamax. So there was a trial came out of Iran, actually, a very good, well-done clinical trial that demonstrated additional benefit of topiramate when you add it to the risperidone. So as an extension of that evidence, we will commonly add the topiramate to any other antipsychotic, whether it's aripiprazole, the Abilify you mentioned. And I've had excellent luck in that context, actually, in many, many instances. So yes, if they're having side effects to the antipsychotic, like you mentioned, in your case, you can add the topiramate, and you have to gradually increase that dosage and watch for potential side effects. But that can be very helpful in both helping to curb the appetite, manage the weight gain with the antipsychotic, but also providing additional benefit for the irritability, which may allow you to stop the antipsychotic once you get up to a therapeutic dose. For topiramate, 200 milligrams a day is the most commonly therapeutic dose, 100 milligrams morning and bedtime.
Okay, thank you.
Oh, you're welcome.
Well, the thing I like least about virtual conferences is you can't give a round of applause afterwards. So thank you so much, Dr. Genovese, for your
for that,
time.
but yeah.
There's a lot of things I
you.
don't like, but one of them is no applause.
Thank you all.
Thank you.
My pleasure. Okay, have a good day.